I'm Dr. Griffin.
And I'm Dr. Taylor. Welcome to Evidence at the Bedside Rapid Review Series.
Yeah, so today's rapid review is a 50-question high-yield sprint designed specifically for internal medicine residents preparing for the ITE and clinicians studying for the ABIM board exam.
Exactly. So before we jump in, make sure you subscribe, like, and share the show with your colleagues who are, currently in the middle of board prep.
Right, because we're doing 50 questions, alternating rapid fire with absolutely no fluff.
Yeah, and evaluating a stroke is kind of like being an air traffic controller. The clinical presentation, like the slurred speech or the facial droop, that's just the radio chatter. But neuroimaging, that's your radar, and you just don't clear a landing without your radar.
I love that analogy. You absolutely need the radar. So let's hit the ER doors. In stroke protocol, time is brain. I'll start us off. What is the initial neuroimaging test of choice for a patient presenting with acute focal neurologic deficits?
A non-contrast head CT. This rapidly rules out a hemorrhage before you even initiate any treatment. So can the physical exam reliably distinguish ischemic from hemorrhagic stroke?
No, neuroimaging is strictly required because clinical manifestations, like headache and impaired consciousness, they just overlap way too significantly.
Exactly.
Which validated clinical scale is universally used for rapid assessment of stroke severity.
The NIH stroke scale, or NIHSS, which ranges from 0 to 42, if a patient presents with the, quote, worst headache of their life, unquote, within 6 hours of onset, how is subarachnoid hemorrhage evaluated?
With the non-contrast head CT. Because if it's normal within the specific 6-hour window, it usually rules out an SAH completely.
Yeah.
But what is the required next step if a patient with suspected SAH presents after 6 hours and their head CT is negative?
Then a lumbar puncture must be performed to check for cerebrospinal fluid xanthochromia.
Got it.
Why is an MRI not the initial test of choice in an acute stroke evaluation, despite being, highly sensitive for acute infarction?
Well, its longer acquisition time delays critical, time-sensitive treatment decisions regarding thrombolysis.
Time is brain.
Exactly. In a patient with suspected large vessel occlusion being considered for endovascular therapy, what emergent imaging is indicated?
You'd want CT angiography of the head and neck alongside CT perfusion scanning.
Right.
What finding on a non-contrast head CT represents a massive ischemic stroke and is an absolute contraindication for thrombolysis?
A multilobar infarction involving greater than 1/3 of the cerebral hemisphere.
Wow, yeah.
What is the preferred initial imaging modality to evaluate for internal carotid artery stenosis?
Duplex ultrasonography, favored for its wide availability and low-risk profile.
Makes sense.
Which clinical presentation strongly suggests a lacunar infarct.
Isolated motor or sensory syndromes caused by infarcts in deep structures like the thalamus or internal capsule, heavily driven by hypertension.
Perfect. So let's transition from diagnosis to acute intervention.
Right, the actual medical management.
And I always think about this. Why not just drop the blood pressure immediately in an ischemic stroke?
Oh, I mean, that's a huge trend.
Yeah, right. Think of the ischemic penumbra like the top floor of a burning building. You need to maintain high water pressure to push flow through those collateral vessels.
That's a great way to put it. You have to maintain that ischemic threshold.
Yeah.
So what is the standard time window for administering intravenous thrombolytics like alteplase or tenecteplase?
Standard benefit is within 3 hours of symptom onset, though off-label use extends up to 4.5 hours. What are the absolute blood pressure targets before administering 5V thrombolysis?
Blood pressure must be strictly lowered to less than 185/1 10 millimeters of mercury.
Right.
And what is the strict blood pressure target after thrombolytic administration?
It must be maintained below 180/105 millimeters of mercury to prevent hemorrhagic conversion.
Got it.
Name an absolute hematologic contraindication to IV thrombolysis.
Heparin use within 48 hours with an elevated APTT or a platelet count below 100,000.
Yeah.
For a patient totally ineligible for thrombolytics, what is the threshold for initiating acute antihypertensive therapy?
You do not treat unless the blood pressure is greater than or equal to 220/120 millimeters of mercury.
Wow, that's high.
Very. If a non-thrombolysis patient does exceed that 220/120 threshold, what is the treatment target?
You cautiously lower the blood pressure by exactly 15% in the first 24 hours.
Exactly.
Up to how many hours from symptom onset can endovascular thrombectomy be considered for large vessel occlusions?
Up to 24 hours, depending on the presence of a salvageable penumbra.
Right.
When is it safe to initiate antiplatelet agents following systemic thrombolysis?
All antithrombotics must be held for 24 hours until a follow-up head CT confirms the absolute absence of hemorrhage. For acute ischemic stroke patients completely ineligible for reperfusion therapy, what is the immediate intervention?
Aspirin administered within 48 hours to rapidly reduce the short-term risk of recurrent stroke.
Good to know.
Does the emergent administration of systemic anticoagulation with heparinoids improve outcomes in acute ischemic stroke?
No. It completely fails to reduce short-term recurrence and drastically increases the risk of hemorrhagic conversion.
Yeah, definitely avoid that. So that covers the acute phase.
Right.
Let's shift focus to preventing the next stroke, moving from antiplatelet rules to cardioembolic and carotid management.
And timing DOACs in AFib strokes is kind of the ultimate clinical tightrope walk.
Oh, absolutely.
Like you start too early and you cause a bleed, but you wait too long and you get another clot.
Such a tough balance. What antiplatelet regimen is indicated for a minor non-cardioembolic stroke with an NIHSS under 6 or a high-risk TIA?
Short-term dual antiplatelet therapy, or DAPT, with aspirin and clopidogrel for 21 to 90 days, followed by monotherapy.
Right.
For standard secondary prevention of non-cardioembolic stroke, what are the acceptable monotherapy options?
Aspirin, clopidogrel, or aspirin dipyridamole are all clinically appropriate. Which antiplatelet agent is strictly contraindicated for patients with a history of prior stroke?
Koshuga.
Got it. What is the preferred class of medication for secondary prevention of cardioembolic stroke due to atrial fibrillation?
Direct oral anticoagulants, or DOACs, are favored. How should the initiation of DOAC therapy be timed following a mild or moderate cardioembolic stroke?
Delay initiation for 2 to 4 days to safely balance ischemic and bleeding risks.
Right.
And what about the timing of DOAC initiation for a severe cardioembolic stroke?
You delay initiation for 6 to 7 days due to the massive risk of hemorrhagic conversion in large edematous infarcts.
Makes sense.
What is the primary indication for surgical revascularization in symptomatic carotid artery stenosis?
Stenosis greater than 70% and select cases of 50 to 69% stenosis.
Okay.
Is routine revascularization indicated for asymptomatic carotid artery stenosis?
No, the absolute mainstay is medical management with high-intensity statins and blood pressure control.
In patients with symptomatic intracranial artery stenosis greater than 70%, what is their recommended treatment?
Aggressive medical management, because intracranial stenting carries a really high risk of procedural stroke.
Wow, okay.
What target LDL level should be achieved with high-intensity statins in patients with atherosclerotic ischemic stroke?
And LDL cholesterol strictly below 70 milligrams per deciliter.
Perfect.
Let's pivot to hemorrhagic stroke, so ICH and SAH.
Yeah, if ischemic stroke management is about preserving flow, hemorrhagic management is strictly about plugging the leak and protecting the container.
Well said. What is the exact target systolic blood pressure in the acute management of an intracerebral hemorrhage?
Between 130 and less than 130 millimeters of mercury, strictly maintained for at least 7 days. Which class of antihypertensive agents should be completely avoided in the acute management of ICH?
Intravenous nitrates, because they can cause venodilation and dangerously spike intracranial pressure. Does administering platelet transfusions improve outcomes for ICH patients bleeding in the setting of antiplatelet therapy?
No, routine platelet transfusion is not indicated here and does not improve functional outcomes at all.
Interesting.
What underlying etiology should be highly suspected in a patient over 50 presenting with a lobar intracerebral hemorrhage?
Cerebral amyloid angiopathy, which severely weakens cortical vessels.
Well,
should a patient with known cerebral amyloid angiopathy ever receive long-term anticoagulation?
no, it must be strictly avoided due to an annual bleeding risk reaching up to 10%.
That's huge.
Very. What is the highest risk complication in the first 48 hours following an aneurysmal subarachnoid hemorrhage?
Aneurysmal rebleeding, dictating that systolic BP must be kept tightly below 160.
Got it.
Around what day post-SH is a patient at highest risk for developing delayed cerebral ischemia from vasospasm?
Typically around day 5, which strictly mandates frequent monitoring with transcranial Doppler. What pharmacologic agent should be administered to all aneurysmal SAH patients to improve outcomes related to vasospasm?
Prophylactic nimodipine for 21 days. How is elevated intracranial pressure temporarily managed in the setting of acute ICH?
With bolus osmotherapy, using mannitol or hypertonic saline, whereas glucocorticoids are ineffective and should be completely avoided.
Okay.
What imaging finding warrants the neurosurgical placement of an external ventricular drain at a patient with SAH?
Obstructive hydrocephalus coupled with a declining level of consciousness.
All right, moving into the final stretch.
Yeah, focusing on high-yield inpatient care and prognosis.
Exactly. Treating the brain is really only half the battle.
Right. I mean, the boards love testing the medical complications on the floor because that's what actually dictates long-term mortality for you.
For sure. What is a leading cause of mortality in hospitalized stroke patients that requires immediate pharmacologic prophylaxis?
Pulmonary embolism, meaning deep venous thrombosis prophylaxis, should be initiated on admission. What is the strict exception to starting DVT prophylaxis immediately on admission for an ischemic stroke?
In patients who received thrombolysis, you must wait 24 hours and confirm the absence of hemorrhage on a follow-up CT.
Yep.
For patients with hemorrhagic stroke, when is it safe to begin subcutaneous heparin or enoxaparin for DVT prophylaxis?
24 hours after an ICH if imaging shows a stable hematoma, or immediately after securing an aneurysm in SAH.
Makes sense.
Should supplemental oxygen be routinely administered to all acute stroke patients?
No, avoid supplemental oxygen unless the patient's saturation drops to 94% or lower, as hyperoxia may actually increase mortality.
Wow, didn't know that.
Yeah. What highly prevalent post-stroke complication is a major modifiable risk factor for long-term disability.
Post-stroke depression, which mandates aggressive routine screening and prompt treatment. Should selective serotonin reuptake inhibitors be given prophylactically to prevent post-stroke depression?
No, SSRIs are not indicated for prophylaxis and actually increase the risk of bone fractures in stroke patients. Good to know.
What specific type of surgery carries the highest risk for causing an in-hospital perioperative stroke?
Cardiac surgeries involving cardiopulmonary bypass, particularly multi-valve procedures that trigger atrial fibrillation.
Right.
How long should elective surgeries be delayed following an acute stroke to minimize perioperative risk?
At least 90 days.
Okay.
If a patient develops massive symptomatic cerebral edema and increased ICP after a large hemispheric ischemic stroke, what is the definitive intervention?
Decompressive hemicraniectomy, providing a survival advantage despite potential long-term neurologic compromise.
Last one.
What hidden cause of post-stroke fatigue must be evaluated with polysomnography because standard clinical questionnaires are totally unreliable?
Post-stroke sleep-disordered breathing, which severely hinders neurorehabilitation.
And that brings us to the end.
Wow, 50 questions.
Fast-paced for sure. But before we wrap up, I want to leave you with a brief provocative thought connecting to all of this.
Go for it. So, will the future of stroke triage move entirely to AI-driven perfusion imaging in the field, like potentially shifting the, quote, time is brain, unquote, paradigm before the patient even hits the ER doors?
Oh, that would completely change the game.
Right. That's our rapid-fire review for today.
Please remember to subscribe, like, and share the podcast. See you at the bedside.